Hello, and welcome to Good Samaritan Spotlight. My name is Dr. Scott Stine. I'm Chief Medical Officer of our physician group here, Men's Sins at Good Samaritan Hospital. Joining me today, Dr. Jane Bridges. She's a diabetologist here, and will be talking with us a little bit today about a technology that helps us in diagnosing liver problems. Now, Jane, tell us a little bit about what your practice is and how this is important for your practice.
Well, my practice is 100% diabetes. 70% of all my patients have fatty liver. And then a certain percentage of those folks will go on and develop liver cirrhosis. And so now there's a lot of pressure on the diabetes world, endo world, to start really screening for fatty liver disease. One of the reasons is we have Fibroscans now, which we now have here at Good Sam. And secondly, we now have some drugs that are coming to market that might help delay or prolong or keep people from developing cirrhosis. So I've started a new liver program. I sometimes feel like I'm a cardiologist, nephrologist, and now hepatologist. Anyway, I'm diving in and we'll learn as I go along.
Well, those of us in primary care are very excited about this because this is something that is in all of our journals that we've talked about for years. And I think we probably should give a little background and discuss part of what drives this metabolically is our obesity issues in our country have been an ongoing problem and rising issue for years. And as a primary care physician, obviously we deal with a little bit more of the easier to control diabetics. Nonetheless, many of those diabetics for us are obese, have central obesity specifically, organ-based obesity and organ-based fat. So talk a little bit about why that is the issue. And I think for many years, the problem was we just didn't have anything to do about this. There was no easy way to evaluate this other than going and punching a hole in somebody's liver, which was a terrible option.
Yeah. I mean, even with a liver biopsy, we still didn't have much to offer until they were cirrhotic and needed a transplant. So, I mean, the obesity is the major issue, and fat infiltrates the liver and it starts to destroy the architecture of the liver such that the liver becomes hardened, and it will progress till it becomes what we call cirrhotic. And there are 4 levels of hardness, and we certainly want to keep people from level 4. So we have some drugs now. Some of the most popular drugs we're using is for weight loss. So that would be your Mounjaro and your Ozempic, or what we call GLP-1s, which have really helped people lose weight, mobilize fat out of that liver, and hopefully preserve a normal architecture. The liver, interestingly, can heal itself. It can regenerate. So if we get rid of the fat, it might heal itself to a stable level. Beyond that, now there's other drugs coming, of which I'm not very much an expert at, so I don't want to go there if you don't mind.
Certainly.
But anyway, detecting, we didn't have really good ways of detecting how fat the liver was and how hard it was without a liver biopsy, which is invasive, costs a lot, and then has risks, predominantly of bleeding. So now we can use, I want to call it an ultrasound-like technique that can very quickly analyze that liver. It tells us the percentage of fat, and we want to keep fat less than 5% in the liver. So anything above 5% we would call a fatty liver. And then we want to detect how hard the liver is.
I think when we look at this, the first thing, which you kind of alluded to already, is this is a very common problem. When we look at most of our diabetic patients, that metabolic type syndrome, most of them are overweight, many of them with that central obesity. And then when we draw labs on these patients, obviously we're looking at what their glucose level is, their A1C and so forth, but frequently part of that is their metabolic panel. And nowadays our patients, they get all of their lab tests the same time you and I do. And so they look and they say, well, it looks like my liver enzyme tests are elevated. And one of the first questions I always get is what does that mean? Mm-hmm. So when our patients look and they say, oh, it looks like my A1C is 6.8, I think you'll be happy with that. But what about this ALT and AST? What does that mean?
Mm-hmm. Well, here's the scary part. You can have a very fatty, hard liver and have normal liver enzymes. So I just want to state that for the record. But if we start to see those liver enzymes elevate, I, in my mind, have a little thing I keep in mind. If the ALT is greater than the AST, that means fatty liver. If it's the opposite, if it's AST greater than ALT, then I start inquiring a little bit more about their alcohol intake. So, but anyway, yeah, we can start to see these liver function tests start to elevate, but they don't really even have to be very high to indicate abnormality with the liver. When they get incredibly high, we of course get very nervous, and then we start looking for other reasons why they would be so high. Another parameter that we have to watch is our platelets. If the platelets are lowering, we're starting to get into some trouble with portal hypertension and things like that. So the liver function test, I think, play a role. They help us calculate what we call the Fib4, which is a standard thing that we calculate in our office visits. Many times I do it and patients don't know it because I have a smart phrase in my on my EMR, but that looks at the ALT, AST, platelets, whether male, female, diabetic, and so it can give me a number that says, this is a person I need to screen, and that helps me narrow it down. So I'm not screening all patients, but technically in my practice, the emphasis is they should all be screened because they have diabetes, but that's going to be a big effort to do.
Oh, for sure. And we're doing this more in more areas of medicine. We obviously do these types of calculations from a cardiovascular risk standpoint, from a bleeding standpoint. You mentioned the Fib4 scoring. These are types of things that we can do that at least give us a better impression as to, is this a higher risk patient or a lower risk patient? One of the other things that you alluded to, which is kind of exciting and which has really been a game changer, is not only is this a problem, but now it's a problem we can do something about. Now, for many, many years, of course, we have counseled our patients on diet and exercise and the importance of weight loss. And many of the patients that I take care of could probably solve or eliminate a lot of their diabetic problems with significant weight loss. But that's very challenging. No different than getting our patients to quit smoking. Significant weight loss that is permanent and long-lasting has been a tremendous challenge. And short of major surgical interventions, which nobody's excited about, there haven't been great weight loss options. And so let's talk a little bit about the medication classes that a lot of people think of as new. They're not really new, but the GLP-1s and a little bit about where they came from and what the evolution of that has become in terms of now we're seeing these medications used for multiple medical problems, not just diabetes.
Right. I think GLP-1s, along with our other diabetes drug, SGLT2s, are going to be very commonly used whether you have diabetes or not. The GLP-1s started from the very old drug called Byetta, which was an analog of the spit from the Gila monster. But that spit had a chemical in there that allowed the Gila monster not to eat for months. And so we'd like that work. Yeah, why can't we do that? Well, we did, but it wasn't great. It was twice a day, not very powerful. And then through the years, we've had things like, Victoza, which was once a day, and then we started going to the once a weeks with Trulicity, and now we have these big guns. We have the Ozempic semaglutide and Mounjaro tirzepatide, and there's more coming in the pipeline. Incredible, including orals too. So we have a lot more tools on hand to help with obesity, but not, when they work, they're great. And then when they don't, then what are our other options? Bariatric surgery is an option for those who can't tolerate it and have not been able to lose. And I will just tell you, it is harder for people with diabetes to lose weight. We all think, just eat less and do more and you should drop pounds. For people with diabetes, that's very hard. We know from our research studies that they lose less compared to a non-diabetic when you compare like Mounjaro or what they've done on these other GLP-1s. So, and then I take care of so many elders, backs, knees, hips don't work to even move much. So I think our patients with diabetes, especially the elders, struggle so much. So the GLP-1s have been life-changing for so many people, but we have to remind them that this is for the long haul. This is not something you lose 20, 25 pounds with and you go off. Patients will regain when they go off these medicines. And then we have concerns, reality concerns about whether insurance will continue to cover these drugs. And then we have our setbacks then after that. So we, every day we're working and struggling to help people stay on these medicines and reap the benefits over the long run, including reduction of fat in the liver, but just healthier living, these drugs are showing nice evidence of reducing progression to end-stage renal disease, what we call MACE, which is our cardiovascular parameters, are being improved upon. So they have so many more benefits, and it'll be exciting to see what's coming down the pipeline that we can offer.
Yeah, and I think, to reiterate, this is not a new drug class. This drug class has been around for quite a while. And it's just in the most recent years that we have seen these better drugs with less side effects, more powerful. And really, they're addressing multiple metabolic factors in the body that contribute to the diabetes. The other exciting thing is when we look back over our careers as to what we used to have in terms of medications to treat diabetes, some of them that probably promoted progression of diabetes or more rapid wearing out of the pancreas, really the things that we have now really target more of the metabolic flaws and problems associated with diabetes with less side effects and very low likelihood for low blood sugar or hypoglycemia. And so all of these things are good. And then add to that the thought that now, as you mentioned, we're using these medications to treat multiple disease processes, not just diabetes, but diabetes, renal disease, cardiovascular disease, heart failure type problems. And so now that we are seeing finally this being used in the fatty liver disease type world, it's pretty exciting because we didn't have much to do about that previously.
We haven't had much to offer. And, since I've been doing the Fibroscans, I've been shocked at how many F4s, cirrhotics I have found. And I kind of feel bad about it, but I didn't have anything to offer and do, but now we do. And so we need to identify these people and offer what we can and get them on a path for liver preservation. So anyway, yes, I think it's kind of interesting about how heart, kidney, and liver are all going together, and we're going to be treating all of these organ systems. But diabetes affects everything. So it makes sense that our therapies are going to be helping preserve many organ systems to keep our patients well longer.
So just talking in general from a metabolic process, when patients come in to see us and they ask us for what diets to follow, they've heard that they should eat this, they shouldn't eat that. They've heard they should stay away from high fructose corn syrup. They've heard that they should eat a higher protein diet and less carbohydrates. And if they eat carbohydrates, they should be certain types. You have just kind of a general suggestion to folks who want to avoid fatty liver disease, to want to stave off diabetes, that want to work on weight loss, anything that you generally offer up to people as kind of a general diet?
I could be honest and say I don't have a lot because Scott, after 33 years of doing diabetes, it is hard to tell a patient how to eat. Sure. Because it goes in one ear and out the other. I can't prepare their food. I can't buy their food for them. So, however, I'll tell you what I have been doing lately. For those patients on GLP-1, there's been a lot of studies or evidence that have come out to help us guide them better because these patients have lost weight, but they're losing muscle. So the current rule, and patients would have to convert their weight into kilograms, but it's 1.3 grams of protein per kilogram of weight. And so for most women, that's right around 90 grams of protein per day. And to just give you an example of what 30 grams of protein would be, 4 ounces of meat or 5 eggs, believe it or not. And so adequate amount of protein. For men, it's going to be around 120 grams of protein throughout the day. We want to minimize our complex carbs. Now, our complex carbs are healthy foods too. It would be your fruits, your grains, your pastas, but we kind of want to limit them for women. Probably if they're interested in weight loss, around 30 grams at a meal. So they're going to have to pull out, their phone or, resources to look up. Men would be 45 to 60 grams at a meal of carb. They get more, lucky dogs. And then the free vegetables, your vegetables that are on your salad bar are predominantly free. You want to keep your fats to a tablespoon at a meal. And then choose your snacks wisely. And I give an example. A quarter cup of mixed nuts, which everybody loves to eat mixed nuts, can be, several hundred calories and all fat. Whereas if you do a string cheese, maybe 6 grams of protein and a whole lot less calories. I think something like maybe 60 to 80 of that. So choose your snacks wisely. And that's what I'm recommending now. But I unfortunately can't give great diet recommendations. For fatty liver, the current recommendation is the Mediterranean diet. And you can buy resources on, Amazon on Mediterranean diets, a nice, healthy diet all around. So that's what I recommend, but I keep it pretty general because I think it's hard for a lot of patients to cook, prep food, buy it these days. And so I struggle with that when working with patients.
It's adapting to each individual person. And I don't have one size fits all diet that I offer anybody. I tell everybody that probably one of the most important things is a diet that you can stick with, because what you and I see frequently is fad diet, weight loss, weight gain, fad diet, weight loss, weight gain. And they do this cycling back and forth, which is unhealthy. But they can't stick with anything long term. And frequently that's because they set unrealistic goals or are told you need to follow this diet by the cardiologist or the diabetologist or the primary care doctor. And they can't do that either because of expense or because it's foods they don't like or whatever. And so, one of the things I frequently early counsel people on is get rid of the easy stuff first, the low hanging fruit, the sugared sodas and drinks and sweet tea and things where you waste lots of calories and carbohydrates. The snacks is kind of the next thing that I usually counsel on, that this is something easy that you can get rid of. Doesn't mean you can't have cake or pie at a birthday party or ice cream during special occasions, but in general,
those are sometimes foods. Yeah. In the old days, our predecessors before us, they talked about don't eat anything white. And when you think about it, that's your white rice, your white flour, your white your white mashed potatoes. Very interesting, but it kind of made sense. Absolutely. So, anyway, because it's well known down here, we have what's called the white meal, which is all white meat or white, potatoes and white gravy and all that. So, and corn with that, because we have the Indiana 3, which is corn, peas, and potatoes. So, Indiana 3. So, anyway, I think diet's hard for patients. It's hard for diabetologists because they go on the fad, and I never tell patients how to eat, so I let them figure it out. They go on the fad diet. I back off on all the insulin. Then they go off. They let their sugars run high. Now I'm cranking back on the insulin. So that's frustrating for us too. And if we could have some consistency in meal planning and how they eat every day, I think patients are much healthier. They'll feel better than having these wide swings that they do with the fad diets. And
it's fascinating to me too. One of the only proven commercial diet plans has been Weight Watchers. And part of the reason for that is it's simple, it's everywhere, it's ubiquitous, it's portion control dieting, which most people can tolerate fairly well. And it doesn't take a lot of education to kind of get started on that. You and I frequently will mention to people that we want you to follow the Mediterranean diet, and people kind of glaze over and they're like, well, I don't eat fish and olives, so I can't follow the Mediterranean diet. And we're like, hey, get online. We've all got these resources. The Mediterranean diet is much broader spectrum than that, but it's kind of just a good general guideline. Mm-hmm. And so again, it's helping to educate people on something that they can follow long term. And then now that we have this where we're really trying to focus in on, okay, this is what's going on with your cholesterol. This is what's going on with your blood sugar. Metabolically, we think that's healthier for your body. Now having this tool of the Fibroscan to help us feel more reassured that something bad isn't happening. Because I think you mentioned one of the things that has always kind of been disturbing to me is we would like to think that we can predict which patients are going to be harmed by this, but we can't. No, we can't. We can't look at them and say that's going to be the issue. So can you describe a little bit about how the test is run? Everybody is going to want to know, do I need to do a bowel prep? Do I have to be anesthetized? Is there anything to do at a time?
No bowel prep. Fasting for 3 to 4 hours before you go. You'll be laid on a table and positioned with the arm behind so that liver kind of pokes out. It is basically like an ultrasound probe. And the technician has got to get 10 good pictures of the liver, and that data then is averaged and gives us a rating of quantity of fat as well as hardness. And then that is interpreted by Dr. Serrano, who's our gastroenterologist, and reports are sent out. And then that's left up to me to figure out what to do next. So, but it's pretty easy. I think it takes under 10 minutes. No anesthesia, no prep, just fasting. So we kind of remove a little what fat we can get out of the liver before going.
And it's accurate. I think when we talk about the FIB-4 scoring and things like that, we're taking multiple parameters and saying, are you an at-risk person or are you not an at-risk person? This testing is saying, hey, is there fat in the liver? And then is that fat causing increased density or hardness? I kind of think of it as ultrasound waves passing back and forth through the liver. It's like you're ringing a bell. If you hit it and it's hard, the ringing goes back and forth pretty quickly. That tells you that your liver is hard. Liver is not supposed to be hard. That's obesity. And so I think the nice thing about this is this is a non-invasive test. We're not poking holes in people. We're not risking bleeding. It gives us a fairly accurate reading that can also then be followed over time.
Yes. So if the patient, drops weight, recheck in a year. It'd be nice to show, hey, you've really, transformed or changed the density of your liver or the fatness of your liver as well. So it'll be interesting to see how I do that over the next several years working with the Fibroscan and how that changes patient behavior maybe as well. So I'm looking forward. We've done a lot of tests already, and I've been blown away what I'm finding. But of course, I was picking patients who I had concerns about and who had elevated liver function tests. And I will say, if you have normal liver function tests, but you've had a gallbladder ultrasound or you've had a CAT scan that just happened to mention, oh, by the way, this is a fatty liver, I would strongly encourage patients to talk with their primary care about going ahead and getting a Fibroscan and getting a baseline, find out where you're at, so that we can follow it over time. And if significant, what changes can the patient make in regards to diet, exercise, weight loss to help reduce or reverse the fatty infiltration of the liver.
Yeah, and this is not an uncommon incidental finding. You mentioned that a patient goes to the ER, has this scan, that scan, has cerebral quadrupane. We double our ultrasound and we find fatty liver type changes. That's sort of the bell ringing going, hey, you need to take a look at this. We may have been preaching to that patient about diet, exercise, and weight loss, but as you described, this is sort of the hallmark moment to say, oh, okay, I've had my first heart attack, my first stent. I really do need to drill down on cholesterol, blood pressure, diabetes management, so forth. Something like this becomes, okay, I've heard you say I need to diet, exercise, and lose weight. Now we're talking about my liver health, and you've alluded to the possibility of cirrhosis. I think a lot of patients, when we mention cirrhosis to them, they think, well, I don't drink alcohol. How am I going to get cirrhosis? Unfortunately, alcohol is becoming a smaller portion of what our cirrhotic patients are. And unfortunately, fatty liver disease and MAFLD, MASLD, all this stuff, all the acronyms now are becoming, this is why our patients end up in the liver clinic, is that, oh my gosh, this has become the cause.
Yeah. The other thing I want to mention, we were talking about GLPs and, for those of us who've had weight issues all of our lives and who approach food differently than a person who doesn't have weight, we know our brains process that information much differently. And so one of the beautiful aspects of using GLP-1s to help with weight loss is what it does to the brain. This is our only drug that crosses the blood-brain barrier. It hits the satiety receptors in the brain and consequently settles down what we call food noise. We're less likely to tell ourselves, oh, clean your plate. We're less likely to tell ourselves to, eat a snack. You're hungry. Keep eating, until you are so uncomfortable. So I think our GLP-1s are definitely a game changer in regards to the treatment of obesity because of how it changes the brain and the brain's response to eating. And I think the majority of our patients with obesity have what I would call disordered eating. They may not have an eating disorder, but they approach and think about food differently. And I'll hear that in my patients. I get up from dinner our evening meal, and 30 minutes I want a snack again. Those are the patients that will benefit from this to settle that brain's desire to feed and refeed all the time. So I think we got some hope on the horizon with these drugs, and hopefully we, with better knowledge and testing, we can kind of turn the tide of fatty liver disease, because quite frankly, the end stage approach is a liver transplant, and we don't have enough livers to help people. And so I think anytime we can reverse fatty liver disease, we're going to help keep our patients alive a lot longer.
And this is a correctable problem. I think sometimes when we start talking about some disease processes, patients think, well, there's nothing I can do about this. There's no way I can impact this. And all of the things that we're talking about today, they can absolutely impact with diet, exercise, medications. And these medicines are very safe. One of the first things that I get asked when I start talking about these medications, either for diabetes or weight loss, is, are they safe? I'm not excited about an injectable. Is this something that I'm going to have to be on long term? And the answer is they are safe. They've been around for a very long time. The side effects worry people, and many patients have the side effects, which is increased reflux, epigastric fullness, bloating, early satiety, things like that. But in fact, it's some of those side effects that help with the weight loss as well.
We're so sick we can't.
Yeah,
Well, that's not always good.
No.
Remember, these drugs are for the long haul, so we want to titrate them very slowly, take our time, let the body adjust so that we do get better satiety, we do back away from food, and hopefully retrain the brain to say, you know what, I don't need all that. I'm fine eating less. And I think then, the other project I've been working on is just maintaining muscle mass. And I'm going to divert here a little bit, but I talked about the amount of protein they need to consume. But in addition, they need to be doing strength training. And it doesn't take much, 10 minutes, 3 times a week of some form of strength training, and then working your way up to 7,000 steps because you've been focusing on exercise. So what concretely can we tell people to do? Strength training, they can do it from a chair. You can Google on YouTube, chair exercises, strength training, 10 minutes, and we'll call them sessions that patients can follow. And then working up to the 7,000 steps, not everybody can do that. But if you're only doing 2,000 steps, can we do 3,000 or 4,000 and a little bit more? So the exercise, like you pointed out, is very important. Backing away from food, portion control, but yet working on maintaining muscle mass so we don't increase the risk of falling and weakness, especially in those elders who are on GLP-1s. And so that's some of the other focus I've been working on to try to mitigate some of the downside of weight loss.
Well, and I think one of the things that's nice about this is to remind patients that it takes just a bit of weight loss to feel better and see improvements in these things. The medications that we're talking about can have up to 22, and even the newer medications that haven't been released at 24, 25% body mass loss, but really just a 5% loss of current body mass changes sleep apnea, blood pressure, diabetes, all of those types of things. Cholesterol, maybe not so much, but almost all of those other metabolic factors, even just a small amount of weight loss, 10 pounds, 15 pounds, 20 pounds makes a tremendous difference. Mm-hmm. And patients feel better, which you had mentioned, knees, hips, weight, back, joints, energy level, they sleep better, they wake up more refreshed. So all of those things have a significant impact. Any other things you want to mention as far as you spoke a bit about if this becomes a concern, the primary care physicians can refer them for this. This process is basically this test gets ordered and then gets performed and then goes through an interpretation process.
Yes, and then the results are sent back to the ordering physician for interpretation. I think that's going to be another area of us doing more education to help primary care doctors like, now what do you do? Yep. Because we don't have enough gastroenterologists. They're overwhelmed. And not all gastroenterologists like liver, just like not all endos like diabetes. So finding those connections and networks is what I've been working on, is like, who can I refer to give me the help I need? So anyway, I'm looking forward to seeing what evolves as I continue to do Fibroscans and where that leads me into maybe educating our staff down the road. So we'll just kind of let it all happen and
We're very excited it's available. We're excited that it lives in your world because, of course, this is all metabolic processes. So we certainly appreciate that, and I know you have advocated for this for quite some time. But thank you for that, and we look forward to having this available to our population.
Good deal. Thank you for having me today.
Thank you for joining us today, Dr. Bridges, for joining us as well, and we'll catch you next time.